Good morning, everyone. Thank you for your patience. My name is Joyce Coleman. I'm the Executive Director of the Vasculitis Foundation. I'd like to thank you for joining us today. We are glad you could join us on this Giving Tuesday, as you may have heard. Just a few housekeeping items before we begin. Please make sure you click full screen in the upper right-hand corner of your laptop screen in order to capture the optimal screen resolution for today's presentation. We have been gathering questions via social media and email, and you can also submit questions through the question box. After Dr. Wechsler's presentation, he will be doing Q&A with the audience, so please keep track of your questions, and then we'll try to get as many of them answered as possible. I just wanted to, this webinar was the brainchild of Suzanne DePaulis, who's a member of the VF Board of Directors. She has EGPA and is an active member of the online EGPA community. She's not able to join us today, which is she really wanted to, so she just wanted to say hello to everyone and also express her thanks for you guys joining us. So today's presenter is Dr. Michael Wechsler. He's a pulmonologist in the Division of Pulmonary Critical Care and Sleep Medicine at National Jewish Hospital in Denver. His areas of research include EGPA, asthma, and eosinophilic lung diseases. I'd like to welcome you, Dr. Wechsler, and thank you for making time for this presentation. You have the floor.
Sure. It's great to be here this morning. I'm sorry we started a few minutes late due to some technical issues, but it's great to be here. What I thought would be helpful would be to go through a little bit about EGPA, eosinophilic granulomatosis with polyangiitis, and then review some of the diagnostic features, the workup management, and then take most of the time for questions. Thank you for the introduction, Joyce. As mentioned, I work at National Jewish, which is a pulmonary hospital in Denver. I've been here for 6.5 years, and before that I was in Boston at Brigham and Women's Hospital. Pretty much my entire career over the last 22 years has focused on eosinophilic lung conditions, but particularly eosinophilic granulomatosis with polyangiitis, and also asthma, eosinophilic asthma in particular. And what I'm excited about is the fact that things have changed so much in the last 20 years since I first saw my first patient with this disease entity 20 years ago, and how things have evolved, and that now we finally have a medication that's approved for the management of this disease. And I think it's really had a huge impact to have new therapies available for management of this disease. I should just disclose that I have worked with several pharmaceutical companies and have received honoraria from several pharmaceutical companies that are listed here. What I'd like to start off is obviously just defining what EGPA is. And EGPA is, as many of you know, eosinophilic granulomatosis with polyangiitis. It was previously known as Churg-Strauss syndrome. It was also known as allergic angiitis and granulomatosis. And it is a disease entity that was first described by Jacob Churg and Lottie Strauss in the 50s, initially as allergic angiitis and granulomatosis, in an autopsy series of people who died from severe asthma, who had rhinosinusitis, high eosinophils, and pneumonia. And they were found on autopsy also to have eosinophilic arteritis, inflammation of the arteries, and granulomas, or scar tissue in multiple organs. And what was important to recognize at the time was initially it was just a pathologic diagnosis characterized really by the asthma and the eosinophilia, but over time it's become recognized as a lot more than that. And it's now recognized primarily as an eosinophilic vasculitis, and it gets seen by several different disease specialties, including hematologists who see people for the eosinophilia, rheumatologists who see people for the vasculitis, pulmonologists and allergists who see people for the asthma component and the allergic component, a neurologist for the neuropathy, and ear, nose, and throat specialists for the sinus abnormalities, and then whatever other organs may be involved, including cardiologists, gastroenterologists, nephrologists. And so it's important for people to recognize this entity. It's a disease characterized by eosinophilic vasculitis, and the vast majority of patients have moderate to severe asthma. Everyone, by definition, needs to have had at one point blood eosinophilia. And then neuropathy is common in about half of patients. Pulmonary infiltrates on chest x-ray. Sinus abnormalities is very common, 90% of patients. And then eosinophilic vasculitis is one of the key features. Another key feature is the presence of anti-neutrophil cytoplasmic antibodies, which occurs in somewhere around 30 to 40% of patients that have this disease entity. When I first saw this disease about 20 years ago, I recognized that it was an interesting disease because it was at the nexus of asthma, eosinophilia, and vasculitis. And that's really where EGPA fits in. It's got features of all those entities. It's an eosinophilic lung condition. It does have vasculitis. It does have eosinophilia, but it's its own entity. And it's its own entity within a group of hypereosinophilic syndromes. And I think that's another important thing to recognize, because part of the differential diagnosis of hypereosinophilic syndromes is EGPA versus some of the other myeloproliferative or lymphoproliferative disorders. One of the key features of EGPA is the presence of lung eosinophilia. And on the bottom slide, you can see many of these pink cells that are infiltrating into the tissue here. Those are eosinophils. The pink granular protein associated with eosinophils can be seen as well on the upper left-hand slide as well. You can see these pink clusters of cells. Those are eosinophils that are infiltrating into the tissue in these diseased patients. It's a rare vasculitis, and it's a vasculitis that's characterized by occurring quite infrequently in the general population, 2 to 4 cases per million individuals per year, maybe up to 6 per million per year. And so there are probably about 500 new cases a year in the United States. In children, it's actually quite rare. There have been, now 20 to maybe 30 case reports in the literature of cases in kids and in adolescents, but it does occur, but it's quite rare. But since about 20 years ago, there have been increased reports of EGPA, particularly in association with asthma therapies, leukotriene modifiers, as well as anti-IgE therapy, inhaled steroids. And in an asthma population, it's actually much more common. It's about 60 to 80 cases per million patient years. Question becomes is how rare is EGPA? Well, I mentioned the data saying that it was 2 to 6 per general population. 2 to 6 cases per million people in the general population. But in an asthma population, we've identified the case report as closer to 75 to 80 cases per million in an asthma population. And we did a study looking at the incidence of Churg-Strauss. This is now published about 13 years ago. We looked at several health maintenance organizations, and we identified that in a general population of asthma drug users, it was around 35 per million person years, with a higher incidence people aged 50 to 69. But there's probably still significant underreporting of this entity because physicians don't recognize it. Most physicians don't know what this is. They've never heard of, or they heard of but forgotten what Churg-Strauss syndrome is. They certainly haven't heard of eosinophilic granulomatosis with polyangiitis. So it's on us to educate them. And in addition to the poor physician recognition, there's probably still underreporting because there are many patients who get treated with systemic steroids, either for severe asthma or for other entities, and they don't get recognized as having the eosinophilic component or the vasculitic component. And there's also other new drugs like higher dose inhaled corticosteroids that may quell some of the EGPA symptoms. Now, there have been several clinical and pathologic criteria that have been used to define EGPA. In 1984, Lanham said that you have EGPA if you've got asthma, eosinophilia, and vasculitis involving 2 organs. In 1994, there was a Chapel Hill consensus conference in which they said you need to have a tissue diagnosis, you need to have eosinophil-rich granulomatous inflammation with necrotizing vasculitis. And then there was the vasculitis classification criteria. So this wasn't diagnostic criteria, but it's a vasculitis classification criteria that was identified by the American College of Rheumatology, and they said, well, if you have vasculitis, then you will have EGPA if you have asthma, eosinophilia, neuropathy, pulmonary infiltrates, sinus abnormality, and eosinophilic vasculitis or extravascular eosinophils. And these criteria are, in the context of vasculitis, are almost 100% specific for EGPA and 85% sensitive in terms of capturing a diagnosis of EGPA. We were part of a European Respiratory Society task force to help define this entity, and we said that EGPA should be defined as asthma plus eosinophilia with at least two of the following: either some biopsy showing eosinophilic vasculitis, neuropathy, pulmonary infiltrates, sinonasal abnormalities, cardiomyopathy, glomerulonephritis, alveolar hemorrhage, palpable purpura, or anti-neutrophil cytoplasmic antibodies. And if you have this constellation, if you have any two of these on top of asthma and eosinophilia, then you really have EGPA. Now, EGPA is said to evolve in a phasic developmental pattern. Oftentimes, there's just an allergic diathesis, so people have allergic rhinitis that progresses into asthma. People also refer to a stage 2, peripheral blood eosinophilia, eosinophilic infiltration to various organs, so high blood eosinophils, and then stage 3 is the terminal vasculitic stage. I don't like these criteria, this terminology. People come to me all the time and say, what stage am I? And people can either skip through, they can go backwards. I find it quite negative to say that someone's in the terminal vasculitic stage because there can be reversibility of some of the EGPA features. But it's important to recognize that, the reason to recognize this pattern is just so that people can have an early sense, when someone has high eosinophils, people should be wary that there's the potential to develop vasculitis. And that's the major point that Lanham and colleagues were trying to make. Most of these stages develop over years, but they can also develop over weeks to months. In terms of long-term outcomes, there aren't a lot of good studies following people, but there was one about 5 years ago by Sampson and colleagues. They followed 118 patients for 6 years. They said of that cohort, 90% lived at 7 years. And the people who were least likely to survive were those people who were over 65 years of age. 29% had long-term remission. 10% of those patients died by 7 years. And of those not in remission, 57% were relapsing on less than 10 milligrams diprednisone, and those who were not in remission were associated with ANCA and higher eosinophils, as well as a higher prevalence of asthma and peripheral neuropathy. Now, EGPA can affect many different organ systems, including the respiratory tract, the nervous system, the heart, the kidneys, the GI tract, the blood vessels, and the skin. In the respiratory tract, it is associated with asthma, but also pulmonary infiltrates. There's potential for alveolar hemorrhage, as well as sinusitis. The most common other side effects are generally systemic symptoms. People get fevers, they get muscle aches, they get weight loss. Cardiac involvement occurs in about 50% of patients. Kidney involvement occurs in less than 50% of patients. And then there can be GI tract involvement as well. The skin is often how people make the diagnosis of EGPA, and usually people present either with nodules underneath their skin or palpable purpura, which can be seen down the bottom right-hand part and the foot of that patient, sort of this raised, reddish, inflamed rash. And these people, if you biopsy the rash, will have evidence of eosinophils and vasculitis. There was an analysis of a cohort also about 5 years ago, 383 patients that were followed over the course of 50 years retrospectively. They said about 50% had neuropathy. Most of the time people were diagnosed around age 50. Half the patients had ear, nose, and throat abnormalities. This is a little bit low compared to my practice, where about 90% have ear, nose, and throat abnormalities. Skin presentation about 40%, pulmonary infiltrates in about 40%, again lower than what I usually see as a pulmonologist, and cardiomyopathy occurs in 1 in 6 patients. One of the key findings is the presence of eosinophilia, and the lower threshold people say is greater than 10% or greater than 1,000, but I've seen 80% eosinophils. I've seen 20,000, 30,000 eosinophils. These generally actually respond quickly to therapy with steroids and or other therapies. But some of the other lab features that we see include a sedimentation rate, C-reactive protein, IgE, rheumatoid factor, and anti-nuclear antibodies. As I mentioned, Anti-neutrophil cytoplasmic antibody is generally positive in about 30 to 40% of patients and associated with kidney involvement, nerve involvement, and biopsy-proven vasculitis. There are two different types of ANCA, P-ANCA and C-ANCA. It's usually the P-ANCA that's involved in EGPA. And it's usually the ANCA is more frequently seen with ear, nose, and throat abnormalities, peripheral neuropathy, less frequently with cardiac manifestations, but is associated with increase in relapses. Now, when I talk to rheumatologists, I feel like they have a different perspective than I do in this entity. They usually think of EGPA as a vasculitis that is happens to be associated with eosinophilia and asthma and ANCA, and that a flare is a flare of vasculitis. But from my perspective as a pulmonologist, I view this as these are people who have asthma as opposed to vasculitis, who happen to have eosinophilia, vasculitis, and an ANCA. And a flare can be either a flare of their asthma or a flare of vasculitis. I get into debates with several rheumatologists about this topic. And I also recognize that there is a spectrum of disease that we want to try to recognize, and people will present either with asthma, may present with eosinophilic pneumonia, and there's probably some continuum between asthma, eosinophilic pneumonia, and EGPA on the other extreme. In terms of understanding what causes this, well, the etiology isn't that well known. There are certainly autoimmune features. There is the association of ANCA, which causes, ANCA binds to the blood vessel walls, causes chemotaxis or recruitment of inflammatory cells that then release their cellular toxins. And, there's possibly a genetic component. We have identified a couple of families in which there is some evidence of heritability, but it's clearly a disorder of eosinophil regulation and proliferation. We've looked at some genetic studies, and we haven't really identified any genes that are commonly seen. We haven't identified any common mutations that are observed in this patient population. And then there's the association with asthma therapies. So people often ask, what's an eosinophil? Well, it's a kind of white blood cell, and it's a white blood cell that is associated with inflammation. Eosinophils release a variety of different mediators. Eosinophils play a role in tissue immunity normally, and they have all sorts of enzymes inside them that they release that can cause tissue damage in response to different stimuli. And so what's going on in EGPA is there's several different theories, but one theory is that an allergen will cause some kind of immune response that will activate different kinds of T cells. They'll activate both T helper 2 cells as well as T helper 1 and T helper 17 cells. When they activate T helper 2 cells, those cause release of different mediators, including interleukin 5. Interleukin 5 activates the eosinophils that causes the tissue damage through activation of and release of eosinophil-derived neurotoxin, major basic protein, and eosinophilic cation protein. But it also, Th2 cells also release B cells, which produce different antibodies, including IgE, IgG4, and ANCA. But Th1 and Th17 cells can also be produced, and they can also cause tissue damage and inflammation and cause some of the granuloma formation as well as vasculitis. But we're still working on the underlying mechanism. As I mentioned, one of the other causative features is something called vascular endothelial growth factor. Dendritic cells are also involved, so can IgG4. And then there's the association with different asthma therapies. We identified back 20 years ago, and this is how I got into the business, was identified several cases associated with leukotriene modifiers, but also with inhaled steroids, with salmeterol, and with anti-IgE. And these were all cases that were either coincidental in nature or that were either the patients just started the medication as their disease was getting worse, or it was due to tapering of steroids in the context of using these asthma therapies. We didn't think that these drugs were directly causative of the eosinophilia or of EGPA. Now, where does EGPA fit in terms of the broad differential of hypereosinophilic syndromes? So there's a broad group of entities, and you can see EGPA in orange on the far right. It's one of the associated conditions, and it's really a disease entity in which there's a defined diagnosis with peripheral eosinophilia, as opposed to many of these other entities, all of which have high eosinophils and can cause tissue damage, and you've excluded infection. But people can just make a lot of eosinophils from their bone marrow, the so-called myeloproliferative patients or lymphoproliferative patients, where people will have some other kind of T-cell rearrangement, which will cause proliferation of IL-5, which will stimulate eosinophils. But there are other types of eosinophilia, including benign, episodic, and associated as well as overlap syndromes. But EGPA is one of the associated conditions with a defined diagnosis. So EGPA obviously needs to be distinguished from other eosinophilic associated infections, cancers, drug reactions, rheumatologic conditions, as well as primary pulmonary eosinophilic syndromes, including acute eosinophilic pneumonia, chronic eosinophilic pneumonia, and the hypereosinophilic syndrome. And what differentiates EGPA from these is generally the strong presence of asthma and allergies, the presence of vasculitis, the presence of ANCA, oftentimes cardiac involvement, although that can be seen with hypereosinophilic syndromes as well, neurologic involvement, and oftentimes it requires therapies other than corticosteroids. So what's the diagnostic workup for EGPA? Well, the routine evaluation is just identifying that there are eosinophils, identifying IgE levels, tryptase levels. Sometimes bone marrow biopsy is helpful, a CAT scan of the chest or chest X-ray, and then ruling out other infections using like strongyloides antibody. But to do a comprehensive workup for hypereosinophilic syndromes really warrants visiting a hematologist and having a bone marrow biopsy done, and then doing a whole series of tests that can help identify if there's, myeloproliferative, lymphoproliferative, or some other etiology for the EGPA. I often get asked, can one diagnose EGPA without presence of vasculitis? Well, you don't need to have a definitive biopsy, but you need to have blood eosinophilia. You should have some form of tissue eosinophilia, and you can use other surrogate markers of disease, including ANCA and EMG. And you should also have asthma or some evidence of pulmonary infiltrates, although it is theoretically possible to have EGPA without other significant pulmonary involvement. And if there's no definitive vasculitis, this could be either possible or probably EGPA. You need to follow these people closely to monitor for vasculitis. So how do we manage people with EGPA? Well, first of all, we need to treat the underlying asthma. And this is, sometimes neglected by my rheumatology colleagues. But, you need to continue bronchodilators, inhaled steroids, leukotriene modifiers like Montelukast are not bad. Anti-IgE can reduce tissue eosinophilia. And you need to remember to prophylax against infection and bone loss and peptic ulcer disease. But other than that, historically the management has been steroids, and more steroids. And usually you treat the high dose for several months. You need to treat early on. They're effective in 90% of patients, but and they work by inhibiting eosinophil colony growth. But the problem is that the disease often recurs, as many people know, as you withdraw steroids. Very few patients can get off of steroids. Not all patients respond to steroids initially, and there's all the side effects of steroids. Steroids cause thinning of the skin, weakening of the bones, adrenal suppression, growth suppression, infections, neuropsychiatric issues, cataracts, and glaucoma, amongst other things. So who can get steroids alone? Well, based on clinical experience, milder patients. So people who have no kidney, GI, heart, or CNS involvement. But the problem is that relapses can often occur at lower doses, and you need to taper slowly. So what do you do if a patient relapses on low-dose steroids? I usually bump up the steroid dose. And if steroids alone don't work, what do you do if steroids alone don't work? You need some kind of add-on therapy. Or if steroids can't be tapered, then you need some kind of step-down therapy. So those are the general three scenarios. Either people will relapse, or steroids alone don't work, you need something else, or you can't get them off of corticosteroids. So what do you do after steroids? So these are historically what we've tried. We've tried cyclophosphamide, azathioprine, which are associated with a fair amount of toxicity, and then other therapies including imatinib, rituximab, IVIG, anti-IgE, mycophenolate or Cellcept, methotrexate have all been tried. But the problem is there have been almost no trials. There have only been case reports, just series and anecdotal evidence. And some of the data is based on other vasculitides or on asthma, and they're not even based on EGPA. One of the most recent studies, which was published last year, was a study looking at adding azathioprine or Imuran to remission induction glucocorticoids for EGPA or other vasculitis. And you can see here, just by virtue of the fact that there's other disease entities that are involved. And one of the interesting things that was seen was that if you're looking at this figure, compared to azathioprine versus placebo, there was no significant difference between these entities. The probability of remaining relapse-free remained about the same with azathioprine as placebo. And that's just that you could do pretty well just with placebo alone. There was no decrease in treatment failures. There was no decrease in relapse rate. There was no decrease in steroid use, and no improvement in asthma or sinus manifestations compared to placebo. So, I mean, the azathioprine did okay, but it didn't do any better than placebo in any of these key outcomes. So what about targeting eosinophils? And so the eosinophil is the major entity that's involved in EGPA, hence the E in EGPA. And there are many potential targets. The one that's been targeted the most is interleukin-5, because that's what causes eosinophils to degranulate and cause them to release their mediators and cause the eosinophils to become active. And we published a paper just last year looking at Mepolizumab or placebo in patients with EGPA. This was a multi-center study that was sponsored by both the National Institutes of Health as well as GlaxoSmithKline, which was gracious enough to provide both support as well as drug for this study. And one of the key features was that Mepolizumab increased the time to first relapse. And so you can see here, it was a small study. There were 136 patients. This is a rare disease, remember, but 68 got drug and 68 placebo. And you can see that patients who were on placebo relapsed much more quickly and with greater frequency compared to people who got Mepolizumab. Now, Mepolizumab works by blocking IL-5. It's a monoclonal antibody that binds IL-5 and therefore prevents some eosinophil activity. And what's seen was eosinophil levels came down, time to first relapse came down, and the annual relapse rate also was decreased. So on average, patients have around 2 to 3, maybe 4 relapses a year. With Mepolizumab, there was a 50% reduction in the relapse rate in terms of flares of EGPA, whether they were asthma flares or vasculitis flares, about a 50% reduction in annualized relapse rate. Most importantly, I think, for patients was the fact that the daily median steroid dose was also reduced by about 50%. You can see here in orange that the dose of Mepolizumab reduced by about 50%. People started off around 11 milligrams, 12 milligrams a day. People got down to 5 milligrams a day on average, as opposed to placebo, where they started off around 10 and they ended up around 10 or 11 milligrams a day. So 50% reduction in steroid dose, and about 20% of patients were able to come off of corticosteroids completely. So EGPA is a complex syndrome characterized by asthma, eosinophilia, sinus disease, pulmonary infiltrates, neuropathy, and vasculitis. And we've recognized that the eosinophil is central to EGPA pathophysiology. We need to distinguish it from other eosinophilic disorders, and an extensive workup should be performed when considering a diagnosis of EGPA. And you should really refer to a specialist with EGPA expertise. There's several EGPA experts around the country or internationally as well. But they're mostly based in academic medical centers, and here at National Jewish, obviously, where I work, but also at University of Pennsylvania, Cleveland Clinic, Mayo Clinic, Harvard, University of California, San Diego, University of Utah, among some of the other areas of expertise. But there is significant morbidity. It can be challenging to treat. You need to treat aggressively, and there are now therapies that are needed to induce remission, that are capable of inducing remission. Steroids are still first-line therapy. They're effective in many people, but they're associated with other side effects. So one does need to consider biologics and cytotoxic therapy in either steroid refractory disease, step-down therapy, or relapses. And some of the questions that we're still trying to answer is, what's the role of other anti-IL-5 therapies, such as Reslizumab or Benralizumab? Those are two other anti-IL-5 therapies that are currently available and approved for eosinophilic asthma. And can anti-IL-5 therapy be used as first-line therapy instead of steroids? Can it be used in acute presentation of EGPA? Can it be used without steroid use? These are all important questions I think we need to try to understand. We're still trying to understand the role of all of these alternate therapies, but now I think that I've emphasized the fact that anti-IL-5 is a bona fide therapy. So I tried to give you a broad overview in a half hour of EGPA. I think we have about 23 minutes to answer some questions. I'm happy to take some questions from the audience.
Great. Dr. Wechsler, thank you so much for this excellent presentation. We will move directly to the questions. Kaylin Young, our network manager for the VPPRN, and Ed Becker, our director of marketing, they're going to coordinate the questions which have been submitted either through social media, email, or the question box. And if you do have questions, please use the question box in the menu on your right-hand side. So Kaylin, do you want to start the questions?
Sure. Well, actually, I may defer to Ed because he has a couple that were submitted before the webinar. And then there are several that are specific to Nucala as we move through some of the other ones that were already submitted. So Ed, do you want to address some of the ones that were submitted prior to the webinar?
Sure. And I would say most of these are about Nucala and specifically. So I'll jump in here. And can my child get Nucala? If so, if not, why not?
So good question. Nucala, I prefer to use the generic term Mepolizumab. I mean, it was approved by the FDA for EGPA. It's also approved for eosinophilic asthma. The approval in EGPA was in those 12 and up. And so depending on the age, it may be feasible. One can always work, even if a drug is not approved, one could try to use the drug off-label and work with one's insurance company. I treat primarily adults. There might need to be some kind of dose adjustment or something to be considered by people. Again, that's an off-label question, but there's no Mepolizumab is approved down to age 12. There's some pediatric studies ongoing in asthma, and so I don't see a reason why your child, particularly if they're above age 12, would not be eligible for this therapy. It's it's an effective drug. There do need to be more studies in the pediatric population.
Okay, thank you. And this is probably the most asked question from the Facebook, and that is, can I stop taking all of my other medications if Nucala works for me?
Yeah, so that's an important question. So there's a broad range of medications that people take, and I would not recommend an abrupt stopping of any medications when starting Nucala. If it's working well, then I would say you should talk to your physician and decide which therapies can be tapered, whether it's the oral steroids, whether it's the other immunosuppressants, if you're on mycophenolate or if you're on azathioprine. I would do it with a great amount of caution because there might be other ancillary benefits of those drugs, and there may be increased potential for adverse effects if you taper those therapies too quickly. So I would be quite cautious in terms of doing that, and I would do that under the supervision of a physician who knows your case well.
Okay, thank you. Another one, can you be on Nucala and Rituxan at the same time? Are there any studies on this, and why would I want or not want to be on both meds simultaneously?
Yeah, so there are no studies. There is the potential for interaction of these medications, and so I would again approach this situation with a significant amount of caution. These drugs do work differently. Mepolizumab blocks IL-5 and blocks eosinophils. The rituximab blocks B cell activity and will prevent antibody formation. If the rituximab is working, then maybe you don't want to stop it. On the other hand, maybe if you start someone on mepolizumab, you perhaps could potentially consider stopping the rituximab as well if it seems to be working well. And we don't have any good answers. It hasn't been studied. There is the potential for interactions. You want to be cautious about tapering or stopping one medication or another. And I would, again, take this up with a specialist with a fair amount of expertise.
Okay, thank you. Okay, a few more questions. How can I be sure if the symptoms I am having are my EGPA or a Nucala side effect?
A good question. Mepolizumab is generally a pretty safe therapy, so it depends on what the potential symptoms that one's experiencing. If they're a new symptom and things were otherwise stable before starting the mepolizumab, then it would possibly be related to the mepolizumab. I would encourage anybody who is having new symptoms while on mepolizumab to report that to the drug company, because otherwise how will they know and how would people like me know that things are occurring? So we do rely on some type of post-marketing surveillance. I think it's a big challenge to identify which symptoms are related to that, or an alternative. What I commonly get asked is, how do I know whether or not my symptoms are related to the underlying disease or to the corticosteroids that I'm taking, and steroid side effects or steroid tapering and adrenal suppression? Again, very difficult to evaluate. You need to take a good detailed history, occasionally check cortisol levels, amongst other things.
Okay, thank you. And these are three questions, but they're all related, and it has to do with fertility. Will Nucala affect my future fertility? Can I use during pregnancy, and can I use while trying to conceive?
Yeah, so there are no published data regarding mepolizumab and pregnancy, and so I would approach it with great caution. GlaxoSmithKline does have a pregnancy registry, and if you're going to get pregnant and you're either on it or have been on this therapy, then I would get in touch with GlaxoSmithKline to report that. In terms of what I advocate for my patients, because there's so much unknown about this relatively new therapy, and we don't have any good pregnancy data, and we don't know what any effects are on the fetus, let alone on a pregnant mother, I would approach use of this therapy with great caution, as I would with any drug in anybody who's contemplating pregnancy. And I can tell you what I've advocated some of my other patients is I've recommended that they try to come off of this therapy for at least several months before they contemplate getting pregnant. Okay. I tend to be very, very cautious in this area. And, the last thing I want to do is cause any kind of harm to a pregnant mother or to a child, or potentially impact a pregnancy. So I tend to be very, very cautious. And one has to balance. If the drug is really doing a great job in controlling the mother's disease, then one has to balance that versus the desire to get pregnant, and then figure out the exact timing. All complicated issues, and again, I would discuss this with your physician and with a high-risk OB person.
Okay, thank you. Last question, interesting one. How can I be sure Nucala is working for me? Are there any tests, and how often should I be tested?
Yeah, so it's a good question. I get asked a lot, which is, how do I know if the drug is working? And so I try to think back of what was the reason that I put the person on the drug to start with? Was it because of frequent exacerbations or flares? Was it because of inability to taper corticosteroids? Was it because of ongoing eosinophilic tissue inflammation? And then I evaluate each of those aspects after usually about 3 to 6 months of dosing to evaluate whether or not it's effective. You can tell whether the drug is doing what it's supposed to do just by looking at eosinophil counts, looking at blood eosinophil counts. They should come down, to certainly less than 100, and oftentimes less than 50. And so you know that the drug is doing what it's supposed to do. The question is how is it benefiting you specifically and your disease? That's another good question.
Okay, thank you. That was very helpful. And Caitlin, I'll send it back to you.
Perfect. Thank you. And Dr. Wechsler, thank you again for answering all of these questions and taking the time today to present to us. So
Sure.
I have quite a few questions. But the first that I'd like to ask you, because there's several kind of pertaining to it, is how does the use of mepolizumab compare to rituximab in EGPA? And more specifically, one that has not got for a patient that has not gone into remission in the past 4 years, but just kind of across the board, do you have information on how it compares, or is it more patient to patient?
Well, there have been no head-to-head studies of rituximab versus mepolizumab in these patients. And in fact, rituximab, there's actually, there's just case series. There have been no head-to-head placebo-controlled studies either with rituximab. So, rituximab is often used in people who have ANCA positivity and presence of antibodies. For people with a more eosinophilic disorder, I would certainly think that anti-IL-5 therapy. Now, it doesn't work in everybody, and people can still relapse, and that's because there are many different causes of relapse and disease activity. But the short answer to your question is there's no head-to-head data with regard to anti-IL-5 versus rituximab. That kind of study does need to be done, but has not been done to date. Of note, rituximab is not currently approved for EGPA. I mean, it's used because there have been no medications approved for EGPA, but there is a need to do more studies with drugs like rituximab in this entity.
Great, thank you. This one is about mepolizumab, but do studies show mepolizumab being effective in oral steroid-dependent EGPA patients, not only for their respiratory disease, but also any GI involvement?
So there are benefits seen with regard to relapses overall, including asthma relapses, and vasculitis, as well as steroid tapering, and including for GI-related symptoms. Particularly if there's eosinophilic tissue infiltration into the GI tract, this drug can be effective. There have been other studies looking at eosinophilic GI diseases that are ongoing, including eosinophilic gastroenteritis, eosinophilic esophagitis, and those studies need to be evaluated as well. Those are not EGPA with GI manifestations; those are different entities. There's a probable role. I can't say definitively with regard to GI involvement across the board, but there's a probable benefit for mepolizumab in patients with GI involvement.
Great, thank you. So now kind of shifting away from mepolizumab to other questions just for about EGPA. So one is, and this question we actually get quite often, are there any diet, vitamins, or lifestyle recommendations as alternative medicines or in addition to the medications that you're taking that you would recommend?
Well, I think it's important for everybody to have a healthy lifestyle and to eat a balanced diet. And certainly if there are foods that people are intolerant to or that seem to cause problems, you know, I think it's, you know, what one's grandmother told them, you know, eat well, sleep well, exercise. All those apply to patients both with EGPA and without EGPA. I don't have any other specific recommendations for people with EGPA, although you know, there are some people who have identified specific foods that can exacerbate their underlying eosinophilic processes, and so you know, I would be very cautious. For instance, there have been case series of different vitamins and supplements that can cause eosinophilia and can cause problems in people. I've had patients who are, you know, on 60, 70 different supplements that sometimes very hard to figure out. But, you know, in the 90s, there was this rash of cases of eosinophilia myalgia syndrome associated with L-tryptophan, for instance, tainted L-tryptophan. But, you know, so I would just be cautious. I tell people, you know, do what in terms of vitamins and things like that. Do what you feel, what you want to do. Don't go crazy with it. There can be potential side effects from some of the over-the-counter preparations. But otherwise, just, you know, eat well, sleep well, exercise.
Perfect. Thank you. And another question, and again, this one is a little more not contentious maybe, but it is a subject that comes up quite a bit, and again, maybe more for a different webinar. But the question was about CBD oil. So CBD oil has become very popular as an alternative to narcotic pain meds and to help reduce inflammation. Do you have any thoughts?
Yeah. I don't have any information about CBD oil. I generally caution people about putting things in their body or on their body that you know, could potentially cause more problems. And you know, if it seems to work for you and isn't causing problems, then great, go ahead. But you know, I don't endorse that for most people.
So do you have, so kind of for both of those questions, because they are very, they're just maybe hotly debated is a better way to phrase that. But do you have any resources or suggestions for a good, for good information that is neutral kind of all the way around, that our patients could visit or look at, that may be helpful? Do you have any recommendations for where to go?
No, but I would try to look at the scientific literature and look for objective, peer-reviewed data. I tend to be very data-driven, and you know, a lot of times, you know, there's a lot of, for supplements and over-the-counter things, there's a lot of marketing that isn't necessarily data-driven. So just be very cautious, because a lot of the things that you can buy at a lot of these kinds of supplement stores and vitamin stores, they're expensive but not effective and can be potentially harmful. So just be very cautious with them.
Great, thank you so much. So I think we're nearing the top of the hour. Joyce, do we want to take a couple more questions, or would we like to wrap up and then provide the remaining questions to Dr. Wechsler to potentially answer at a later time?
So a couple questions.
Why don't we take a couple more questions and then wrap things up?
Okay. So one of the questions that's come in is about peripheral neuropathy. Is there any way to heal it or alleviate some of the symptoms or the pain that's caused?
Yeah. So peripheral neuropathy, I'd say, is one of the biggest challenges in the management of EGPA, because the pain is often persistent. There can be regrowth of some of the nerves, but any long-term benefits, oftentimes there's damage that's done. and the damage oftentimes is not reversible. But there can be a reversible component, but it can take a lot of time. There's a lot of people who see pain specialists for management. I think one of the key things in the management of EGPA in people who have neuropathy is just to prevent further neuropathy from occurring. And you can do that using some of the medications that we've discussed and some of the steroids. But in terms of people who have active neuropathy, not a lot has been shown to reverse it, but goals to try to improve it as best one can.
Okay, thanks. The other question that was submitted to me was on fatigue. Patients are not sure, is the fatigue caused by the disease, by the medications, a combination? And do you have, what do you suggest for your patients?
Yeah, all of the above. The fatigue can be from the disease itself and the inflammation that's ongoing. It can be from, and I think this is in most cases probably from the corticosteroids that are used to treat the disease, and tapering of corticosteroids is associated with it, adrenal insufficiency, and so lack of adrenal disease. So a good adrenal workup is what I do, I work with my endocrinologist to try to get people on an optimal dose of corticosteroids.
Okay. So that was all the questions I have. Kaylin, Ed, do you have any other quick, well, we'll stop the questions now since we're coming up on the end of the hour. Again, Dr. Wechsler, I just wanted to say thank you very much for giving the presentation today and spending your time with us. We greatly appreciate your support and all your research on the disease and helping improve patients' lives. So thank you very much. Many of you have submitted questions, so we'll bundle them together and we'll send them off to Dr. Wechsler. And if he has time, maybe he can answer some more of them. We have recorded this webinar, and so after we edit it, we will be putting it in the library on the website to watch, or if you want to share it with one of your family members or somebody who's missed the webinar today, please do that.
Or if you have a hard time falling asleep, it's probably good to watch.
Great. And my final thing is, I just wanted to wish everyone a very happy holiday season. We are in our VF annual appeal Join Our Journey campaign. Today is Giving Tuesday. We are asking people to support the VF through the Giving Tuesday, either through the website or through social media. And we want to thank everyone who's already donated. We have a $10,000 matching gift today. So any donation you make will be matched up to $10,000. So we're very excited about that. But I just wanted to thank everyone again for attending, and have a great day.